This program is brought to you by Emory University.
Welcome to this presentation, Hepatitis A, B, and C, Diagnosis and Treatment in HIV-Infected Persons. Your presenter today is family nurse practitioner Diane Wire. She recorded this session on July 14th, 2011, and it is 1 hour in duration. This is a picture of your presenter today, Diane Wire. The intended audience are physicians, nurse practitioners, physician assistants, and others who provide medical care to HIV-infected persons. No continuing education credit is available for this lecture. This is produced by the Southeast AIDS Training and Education Center, or CTEC for short, in the Emory University School of Medicine, with production support from Emory Center for Interactive Teaching. Funding support was provided by the HIV/AIDS Bureau Division of Training and Technical Assistance and the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Our grant number is H4A-HA00067.
Hi, I'm Diane Wire. I'm a family nurse practitioner and an HIV clinical consultant. I need to disclose that I am on the Speakers Bureau for both Bristol-Myers Squibb and Boehringer Ingelheim. Let's start out with a little bit of a pop quiz. Which of the following is a potentially sexually transmitted infection leading to hepatitis? Hepatitis A, hepatitis B, hepatitis C, both hepatitis A and B, or both hepatitis B and C. So that would be all of the above. If you answered all of the above, you're correct. Partly what we're going to talk about now is we're going to talk about how each of the top 3 hepatitis can also be a sexually transmitted infection, which might be new information for some of you. We all remember that the term hepatitis stands for inflammation of the liver. A little information about the liver: it's approximately 3 pounds, and that's for a male body. No one's really able to tell us how much the liver weighs in a female, but the size is about the size of a football. It is located in the upper right side beneath the rib cage. And another tidbit of information is it pumps 1.5 quarts of blood through it every minute. So it's a very important organ for us. So let's talk about the first of our alphabet soup, hepatitis A. If you see in this slide, this graph is from 1980 to 2005. And what you can see is there were quite a number of cases, reported cases, in the 80s and 90s. And then when a vaccine was approved in 1995, and from there for the next 10 or 15 years, what you can see, of course, is there was a drastic reduction in cases. So we know that vaccine works. We know that the recommendations for vaccinating patients who have HIV is if they are not already immune to hepatitis A, we do recommend vaccinating them. Now, what about transmission? Many times hepatitis A has been thought of to be only with small children in daycare centers and older folks in nursing homes. But the reality is that it's an oral fecal infection. Therefore, remember that transmission occurs through contaminated food and water and oral or anal sex. So who's at risk for this infection? Well, we still consider children in daycare centers. We still consider workers in daycare centers because remember, children do not know infection control. Any kind of institution where you have lots of people, military, and then men who have sex with men, MSMs. The incubation period lasts about 2 to 4 weeks. And transmission can occur during this asymptomatic time. Individuals, like many other infections, are highly infectious but are unaware that they have the infection. So what about laboratory tests? Hepatitis A virus, IgM, would be the first antibody on the scene. So it would indicate either current or very recent infection. After someone goes through their hepatitis A and the virus actually resolves, or the symptoms resolve rather, they're going to develop hepatitis A virus, IgG, which of course indicates past infection and or vaccination. So with hepatitis test, It's confusing about which ones I need for what. If you want to know whether someone's a candidate for hepatitis A vaccine, you want to know whether or not they have antibody. So the basic test for hepatitis A is hepatitis A virus antibody test. With hepatitis B, it's a little bit more confusing. You want to know, is the person infected with hepatitis B, or are they immune to hepatitis B? If you want to know whether they're immune, you're going to be looking for hepatitis B surface antibody. We'll talk more about that later. Hepatitis B virus core antibody, which we also will talk about when we get to hepatitis B. Or does the patient have infection? Are they chronically infected or are they infectious? And the blood test for that is hepatitis B surface antigen. And then for hepatitis C, very similar to hepatitis A, you're simply looking to see whether the person has antibodies. And remember, you can't have antibodies if you haven't had the infection, unless of course you've been vaccinated. We do not yet have a vaccine for hepatitis C, so if the individual has antibodies, that indicates that yes, they've been infected. And again, we'll spend some time on hepatitis B and C. So hepatitis A, the infection is very self-limiting, about 8 to 12 weeks. Jaundice usually signals the end of the infectious period. And jaundice is not a very common symptom of hepatitis A. Most individuals who acquire hepatitis A will become immune. They will have lifelong immunity. About 98-99% of the individuals. Treating someone who's actively infected with hepatitis A and who's symptomatic is basically supportive. You can offer post-exposure immune globulin if you believe the person has been exposed to hepatitis A and there's not time to get them vaccinated. And you must give that within 1 to 2 weeks of exposure. Vaccination recommendation for hepatitis A would include anyone who's traveling to what we consider endemic areas, anyone who's got a chronic liver disease, including hepatitis Z virus, which we'll talk about, men who have sex with men, daycare workers, food handlers, sewage workers, and then for all of us who work in the HIV world, any of our patients who are HIV infected. Prevention is really the key. And how can you prevent hepatitis A? One of the most important ways is to wash your hands. But remember also that hepatitis A can be a sexually transmitted infection. So in addition to washing your hands, the use of any kind of protection while having sex is recommended. So this may seem like a silly slide to have in there, but the reality is that many times we are exposed and infected with germs that we're unaware of. So let's move on to hepatitis B. Again, what you'll notice here is that there was a high incidence of acute hepatitis B in the 80s and in the early 90s. And of course, with the approval of the vaccine, and not only the approval, but the recommendation that large populations of individuals be vaccinated, you can see there was a drastic decline in hepatitis B. And by 2008, the number of cases really plummeted. And that's a good thing. So how is hepatitis B transmitted? It is a blood-borne pathogen. Therefore, sexual transmission occurs and perinatal transmission occurs. And any other kind of activity where there is blood-to-blood transmission from one individual to another is actually more infectious than HIV. Now the good news with hepatitis B is if you acquire hepatitis B, about 85 to 90% of individuals will recover with lifelong immunity, much like hepatitis A. 50% recover if they are also co-infected with HIV, so people living with HIV and AIDS. However, those with chronic hepatitis B, the 10 to 15% who are not lucky enough to develop lifelong immunity and who develop chronic hepatitis B, a small percentage, 10 to 20% of those will develop cirrhosis. and about a fourth of those will decompensate. And unfortunately, another percentage of those individuals will develop chronic disease and actually develop hepatocellular carcinoma, or cancer of the liver. But the good news is to remember that the majority of individuals who are infected with hepatitis B will actually go on to develop immunity, lifelong immunity, and those who have HIV, though have a less percentage of developing lifelong immunity, still about 50-50 will.
Question. The goal of treating chronic hepatitis B is 1. To prevent progression to end-stage liver disease and hepatocellular carcinoma. 2. Prevent further transmission of hepatitis A and C. 3. Promote a cure in 100% of cases. Or 4. All of the above. The answer is 1. Prevent progression to end-stage liver disease and hepatocellular carcinoma.
So what about hepatitis B virus and HIV co-infection? Co-infected patients have higher hepatitis B viral DNA levels, lower ALT levels, and lower rates of seroconversion, meaning that when you vaccinate your individual who's HIV infected, the seroconversion of immunity is much, much less. Also, co-infected individuals have a higher risk of cirrhosis. They have a condition that they can develop called IRIS, immune reconstitution inflammatory syndrome, or inflammation, which I'm sure you have heard about or would hear about, reactivation with stopping heart, or antiretroviral therapy. This would be when an individual is on antiretroviral therapy, and in that regimen is included a hepatitis B medication. As I'm sure you've heard with antiretrovirals, some of those medications are also good hepatitis B drugs. And if you stop those drugs, hepatitis B in the individual will flare back up. If you look at the graph on the right, you'll notice that the mortality of the liver is enhanced if the individual is co-infected. If the person has no HIV or hepatitis B, obviously the liver mortality by HIV is not going to be impacted. If they are simply mono-infected, meaning they only have hepatitis B, they do not have HIV, you can see that 0.8% mortality is listed. If they only have HIV and not hepatitis B, the mortality is still a little higher. And remember, that's partially because HIV affects the liver by itself. But the very far right graph, 14.1, you'll notice that's HIV and hepatitis B virus co-infection, a significant increase in mortality. Therefore, hepatitis B vaccination is recommended for all patients who have HIV. So our next question, which of the following set of lab results indicates active hepatitis B infection? Hepatitis B surface antigen is negative. Hepatitis B surface antibody is positive. Hepatitis B E antigen is negative. Or B, hepatitis B surface antigen is positive. Hepatitis B surface antibody is negative. Hepatitis B E antigen is positive. Or C, hepatitis B surface antigen is negative. Hepatitis B surface antibody is negative. The last answer for C, hepatitis B E antigen, is negative. I think you probably would gather that all of the above is not the correct answer, and none of the above is the correct answer. So I'll give you a couple of minutes before we go on to, a couple of seconds really, before we go on to the next slide, for you to figure that out. If you answered B, you're correct. Hepatitis B surface antigen positive, hepatitis B surface antibody negative, and hepatitis B E antigen positive. So let's talk about that. This is a diagram to hopefully help sort out what can be very confusing when you're doing lab tests for hepatitis B. Remember that Ag is antigen. That's from the virus. That's not a good thing. It's the first thing that hits the body whenever the body sees an organism it's unfamiliar with. AB stands for antibody. That's what the body develops in response to the antigen. In this picture you can see it's a circle with 3 layers basically. E stands for envelope, C stands for core, and S stands for surface. It's pretty simple actually. Hepatitis B E antigen is when the virus is actively replicating. Usually first on the scene, highly infectious stage of the infection. Hepatitis B core, or C, antibody, is a previous viral infection. It says exposure here, but I'd like to use the word infection because you can say someone's been exposed, but that doesn't necessarily mean they've been infected. But if the hepatitis B core antibody is positive, this individual has actually been infected with hepatitis B. Hepatitis B surface antibody is exactly what it says. On the surface of the cell, there is antibody. That's going to indicate immunity. Hepatitis B surface antigen means infection and infectious. As long as someone has hepatitis B surface antigen, they are infectious. They're not immune. If you have surface antibody without surface antigen, you're immune. That means that you've been infected with the virus or you've been vaccinated, but regardless, you are immune to hepatitis B.
Question: true or false? Patients who have been infected with hepatitis B and develop a core antibody but do not develop surface antibody are immune to hepatitis B and should not be vaccinated. The answer is false.
So before we can decide whether or not to treat someone or whether or not they need to be vaccinated, it's important to establish a baseline. Hepatitis B E antigen and antibody to hepatitis B E status. If you have the answer to this, you have a sense of, is this individual still infectious or have they developed antibody to hepatitis B E, that viral replication enzyme we mentioned earlier? What is their level of viral load for hepatitis B? That's hepatitis B viral DNA level by PCR. What about their liver enzymes? Are they elevated? Are they normalized? And is there the presence of clinical cirrhosis, either by history, physical exam, or lab work? Does the individual have jaundice? Do they have ascites? Is there palmar erythema or spider angiomas? Is the individual suffering with low platelets, prolonged coagulation parameters, or low albumin? And if so, is the patient compensated or decompensated? And was there ability to do liver biopsy? And if so, what was the histology from the liver biopsy? The next 2 graphs are going to show what happens either when a person recovers from hepatitis B and develops lifelong immunity, or they are one of the 10 to 15% who developed chronic hepatitis B. So in this slide, you'll see in the pink, hepatitis B E antigen, which remember is one of the first antigens on the scene for new hepatitis B infection. But what you'll notice is that weeks after exposure, that antigen turns into antibody. If you look down on the graph, you'll notice that about 4 weeks after exposure or infection, the surface antigen is elevated. And it can stay elevated for quite some time. Hepatitis B is not an infection that resolves very quickly. That's why there's these larger numbers on the graph at the bottom, and those are weeks. So we start out at 0 and we go to 100 weeks. So when you're doing your lab test, remember that doing lab tests with short intervals will maybe possibly not give you the information that you need. You really need to understand that this is a very long process. So total antibody to the core, which is total antibody, hepatitis B, C, or core antibody, develops pretty quickly. Once the antigen gets into the core and it has to replicate, or the nucleus of the cell has to replicate, it develops antibody, and that person will have antibody throughout their life. You'll also notice that IgM drops down after several weeks, and you end up with IgG. Though it's not mentioned on this slide, that's what's replacing IgM. Remember, both of these antibodies indicate different stages of infection. IgM, for me, the way I remember it, is the first antibody on the scene, and it means that the virus is mounting a response in the body. IgG means that the acute phase is over and gone, and you're left with your lifelong immunity or lifelong antibody. Now, unlike the previous slide, this individual developed chronic hepatitis B. They are not immune, and in fact, they are infectious. So where you were looking previously at the pink bar at the top, you see the hepatitis B E antigen. In the previous slide, that E antigen had a very short life relative to this slide. And the antibody to hepatitis B E antigen did not occur here until probably a year or so later. So one of the ways you can pretty much figure out if your patient is going to have acute and then resolved hepatitis B or immune status, or whether they're going to be the unlucky few and develop chronic hepatitis B, is to do serial tests on your hepatitis B E antigen. Remembering, of course, to do them several weeks apart to give you a better sense of where you're really headed. This is a worksheet that I've used many times in the past to kind of give you a snapshot, if you will, of the lab test. So with acute hepatitis B, you will have surface antigen, because remember, the infection is going to hit the outside of the cell first. You will not have surface antibody with acute hepatitis B because it hasn't yet gotten into the core and developed antibodies. You also, with acute hepatitis B, will have hepatitis B E antigen. You will have that viral reproductive enzyme that's very, very active. You'll not yet have antibody to that, and you will maybe potentially have hepatitis B core antibody, depending how long it takes to make the antibody. You will have immune globulin M, IgM, antibody to the core, and you will have hepatitis B virus DNA or a viral load. And very often with acute hepatitis B, the ALT will be elevated. If you're immune to hepatitis B, you will not have surface antigen. You will have surface antibody. You will not have E antigen, and you may or may not have antibodies to hepatitis B E antigen, but you will have core antibody. You will not have IgM because the acute infection is gone. You will not have a viral load because you're immune, and your liver enzyme should be normal. Now, what about if you're vaccinated? Well, clearly you don't have surface antigen because you have immunity, and you do have surface antibody indicating immunity, but what you will not have is you will not have core antibody. That also will be negative. The only thing that you will have is surface antibody. Vaccination is going to provide protection on the outside of the cell, but the only way you can have core antibody is if you actually had infection, the infection got into the nucleus of the cell or the core and was able to develop antibodies. And also your liver enzymes will be normal. Chronic hepatitis B, you will have surface antigen. The immunity is not there, so you will not have surface antibody. You may very likely continue to have hepatitis B E antigen. You won't have antibody to it. And you will still have core antibody to hepatitis B, but that core antibody was not able to get out to the surface, thus being a chronically infected hepatitis B patient. And most likely your liver enzymes will be elevated. For chronic carrier, again, the person is going to have surface antigen and core antibody, and your hepatitis B viral load may be elevated, or it may be non-progressive and it may be low. And your enzymes actually may be normal as well. So what about treatment? There is treatment for hepatitis B, and for patients who have HIV who are co-infected, it's important to understand perhaps how to do the treatment a little differently. So, is your patient a candidate for HIV therapy? The newest guidelines, of course, recommend that therapy start with T cells less than 500. And of course, you always want to make sure that you stay in touch with the most recent guidelines. So if your patient is a candidate for HIV therapy anyway, then yes, they are also a candidate for hepatitis B therapy. And if so, you're going to treat both. If they're not a candidate for hepatitis B therapy, then you don't. If hepatitis B therapy is indicated, but they're not a candidate for HIV therapy, let's say their T cells are 800 and they have hepatitis B, then you would only treat the hepatitis B. You'd still continue to monitor the HIV parameters, but you wouldn't treat the HIV. One of the biggest challenges we have with hepatitis of any sort, whether it's A, B, or C, or whether it's caused by alcohol or whether it's caused by drugs, is that alcohol is competing for liver sites. So we always recommend to our patients to really limit, if not abstain from alcohol, if at all possible, if they are co-infected with hepatitis of any sort. There are many recommendations and expert resources that we encourage folks to look at in terms of selecting candidates for treatment and also in selecting medications for treatment. And it's also important to try as best you can to include medications in the antiretroviral regimen that covers hepatitis B. The goal of treatment for hepatitis B has many layers. You really want as best as possible to normalize the transaminases. You want to eliminate and or suppress the hepatitis B viral replication, very much like we do with HIV therapy. We want to get our virus undetectable if at all possible. We want to get rid of that hepatitis B antigen. We want to seroconvert it to an antibody. And remember, that can be a very long process. So treatment can actually make that process a little bit shorter. We want to lose the hepatitis B surface antigen. We don't want that person to be chronically infected. And we want to replace it with surface antibody. And then, of course, one of our major goals for hepatitis B treatment is to prevent progression to end-stage liver disease and certainly hepatocellular carcinoma. So all of these are very important goals that we have to consider with treatment. Some of the available hepatitis B viral therapies, you have some on the left that are against HIV and hepatitis B, and the ones on the right that are only against hepatitis B. So lamivudine, imtrasibdingine, and tenofovir are all drugs that you would use if the individual is co-infected with HIV and you want to treat their HIV. You want to make sure that these medications are included in their HIV regimen. And the ones on the right are for hepatitis B only. What about hepatitis B vaccine? This is something where we're at a process in our country and in our medical community where we need more information about vaccinating our HIV infected patients. Seroconversion rates to primary vaccine series is very low in HIV co-infected. We might need to consider alternative strategies in order for patients to be protected. There have been few but ongoing studies in terms of whether we should be doing a double dose vaccine in primary series for our co-infected patients. You can see at this slide, the healthier the CD4 count, the more likely the double dose of vaccination will provide immunity. 39.3% for the standard dose for someone whose T cells are greater than 350 versus 64.3%. If T cells are less than 350, only about 26% of folks are seroconverting with the standard dose, and even with the double dose, it's about the same. Viral load, the same, and it kind of makes sense if you think about it. The more the virus is impacting the immune system, the less likely the vaccine is going to have an easy time of developing immunity. So like I said, there's some ongoing studies, and it may be that down the road that the normal recommendation is that all HIV co-infected patients, or HIV patients rather in general, be vaccinated with a double dose of vaccine versus the standard dose. The majority of HIV infected patients with isolated antibody to the core, but who do not have surface antibody, are not immune to hepatitis B or to hepatitis B infection. And the recommendation is that these individuals should be vaccinated with a complete series of hepatitis B vaccine. This is a very common question that we get. My patient is surface antibody negative, but they're core antibody positive, meaning of course that yes, they did have infection at one time, got into the core, it replicated, it developed antibody in the core, but the core antibody was never able to push out and get to the surface. So they're neither infectious nor are they immune. Those individuals need to be vaccinated. What about long-standing immunity? If the vaccine is effective, in other words, the individual who's received the vaccine, their 3 doses, given the way they're supposed to be given, what about lifelong immunity or long-term protection? We don't have an actual number of years. We know that the immunity is going to persist despite the loss of some of the surface antibody. And what that means is when you get your antibody test from the lab, you frequently will see that it's listed as less than 10 or less than 2. But hepatologists tell us that even despite the fact that your lab test says the person has lost some of their antibody on the surface, that they still have immunity. The documented protection is probably up to 15 years, but we really don't know whether lifelong protection is likely. The one strong recommendation is that we should not be boosting individuals. What we need to do is we need to make sure that after the individual has completed their series of shots, that we actually do an immunity panel. We do see if there's surface antibody present. If the person's developed immunity, their surface antibody will be very high. If not, there may be recommendations to revaccinate and go through the series. But we don't boost despite the fact that it may have been years since the patient was vaccinated. The only exception would be is if the person also is on hemodialysis. So let's move on to our last letter in our alphabet, hepatitis soup. Hepatitis C. This is a very interesting history of hepatitis C in our country. You can see by this graph, which goes through 2008, that again, in the 80s, we had high incidence of hepatitis C, with the peak around 1988, 1989. And then it has dropped off. Does that mean that people are not acquiring hepatitis C? Probably not. But one interesting thing about hepatitis C is that you can be infected with this virus for 2 to 3 decades without any symptoms. Here is some more data to kind of point out the difference between this hepatitis and the others we've talked about. Between 1985 and 89, new infection or cases that we knew about per year was about 242,000. In 2005, we had 20,000 new cases. Now, this may be partially because the blood supply, when people donate blood, now tests for hepatitis C. So we actually have more data coming from that pool. But still, as you can see by this slide, fewer new infections that have been reported. Persons with chronic infection to hepatitis C, in the millions. Probably somewhere between 2.7 and 3.9 million people. The individuals, the percentage of chronic liver disease related to hepatitis C, about 40 to 60%. So a lot of the incidence of our chronic liver disease amongst people is related to hepatitis C. Deaths from chronic hepatitis C per year in 2004, somewhere between 12 and 41,000. These were actually estimated cases. Liver cancer, percentage of liver cancer due to hepatitis C, you can see the number is going up drastically from 1993 to 2006, with almost 50% of liver cancer due to hepatitis C. The predicted future prevalence of hepatitis C in the United States, you can see in the 90s, total people infected, and it's dropped down. Infected greater than 20 years, you can see that number has gone up, and then gradually going down by 2030. But this goes back to what I mentioned earlier about that long period of time of infection without symptoms, 20 to 30 years. So the natural history of hepatitis C is very different from hepatitis B. You become acutely infected, and unlike hepatitis B, chronic hepatitis C is going to happen within 75 to 85% of individuals who are infected. And of those, about 20% are going to develop cirrhosis. So what makes progression faster? Well, there's a couple of variables I've included on the right side. One of those is the age of the individual at the time they acquire infection. Older age and infection is going to lead most likely to faster progression. What about the consumption of alcohol? As I mentioned earlier, alcohol and liver infection of any kind really is a bad match. If the individual is also co-infected with HIV, hepatitis C may also have a faster progression. And those individuals who have received transplants of any sort.
Question. Those individuals infected with hepatitis C will develop chronic hepatitis C in what percentage of the time? A, 10 to 15%, B, 15 to 30%, C, 30 to 70%, or D, 70 to 85%? The answer is D, 70 to 85%.
So the risk factors that are more common in cases and in controls. Sexual risk factors. For many years, individuals were told that hepatitis C was probably not effectively transmitted through sex. And the reason this is considered, the title of this slide is called Risk Factors More Common in Cases Than Controls, is that because the data really didn't point to it being a sexually transmitted infection. But the reality is, we know that there are sexual risk factors. It is a blood-borne pathogen. So unprotected insertive or receptive anal intercourse, because of the mucosa, because oftentimes there can be tear, and if there's tear, there can be blood involved. That's going to potentially increase the risk. What about how many sex partners you've had in your lifetime? Certainly, the more chances of infection is going to be greater, the more sex partners you've had. Passive or active rimming, insertive or receptive fisting, use of sex toys, lifetime sexually transmitted infections. Remember that sexually transmitted infections degrade the integrity of the skin, which is a wonderful barrier for all these infections that require a port of entry. Group sex participation, some group sex practices, which I've listed in the bottom. What about drug risk factors? If the individual has used recreational drugs in the last 12 months, that's considered a risk. Crystal meth. Crystal meth is a drug, a recreational drug, that results in hypersexuality. People have lots of unprotected sex when they're under the influence of crystal meth. Ketamine, GHB, all of these other recreational drugs we've listed here, these all can potentially lead to risk for hepatitis C because of the blood-borne pathogen connection. And remember not to forget nasal straws and crack pipes, as those are going to, again, impair the integrity of the skin either in the nasal cavity and on the lips, leading to breakdown of the tissue, blood, and therefore transmitting the blood onto either the nasal straw and or the crack pipe. Other routes for drug risk factors would also include rectal. Some individuals have actually inserted some of these recreational drugs in their rectum, and because of the breakdown of the drug in the mucosa, it's formed a port of entry. So what about screening for hepatitis C? The recommendation is that all men who have sex with men should be screened yearly, and especially if any of the previous risk factors are indicated in your patient's history. Also think of acute hepatitis C with any elevation of liver enzymes, even if the individual does not have symptoms of hepatitis. And allow for early recognition and intervention when you screen. What about treatment for chronic hepatitis C and HIV infected patients? In the perfect world, we'd love to consider treatment if the T cells are greater than 350. Of course, T cells greater than 350, or ideally even greater than 500, would mean that the immune system is rather competent. We'd like to have a lower viral load with the HIV also, especially if the individual is not already on antiretrovirals. If they're on antiretrovirals, of course, we would like to have an undetectable HIV viral load. We'd like to think that we could have a better outcome if there was the absence of decompensated cirrhosis, and if liver enzymes were normal or only slightly elevated. And what about contraindications to interferon or ribavirin? And what about the level of fibrosis? These are all considerations for treatment of someone who has HIV and co-infected with hepatitis C. So those were the physical considerations. What about the social barriers? I've already listed some of the risk factors that included substance abuse. I've already talked about how alcohol can certainly be a challenge with someone who's co-infected. So ongoing substance abuse can be a barrier to treatment. Psych history, depression and psychosis. We know that some of the medications used for hepatitis C treatment can worsen depression and can lead to psychosis if there's underlying mental health disease. And some of them can be contraindicated for that reason. What about unstable living situations? Treatment for hepatitis C is somewhere between 9 months and 1 year. So an unstable living situation may be a huge barrier. Hepatitis C treatment is also incredibly expensive and requires multiple and frequent visits for medical management and evaluation. Another social barrier would be poor adherence to HIV therapy. If an individual is co-infected and they've had difficulty taking their HIV medications, it's going to be very challenging for them to take HIV medicine as well as hepatitis C therapy, or even hepatitis C therapy by itself. So we've talked about physical barriers, some social barriers. We can't forget about system barriers. Presently, there's a lack of provider expertise for treating patients who are co-infected. It also requires extra support staff. It almost requires cheerleaders in the clinical office to support the patients who are undergoing hepatitis C therapy. The therapy makes people very, very ill. And without the sufficient number of support staff to cheer the patient on, oftentimes patients will drop out of care. Our infrastructures need to be modified and designed to allow for increased support and also to increase the numbers of providers who are willing to learn how to treat. And what about liver biopsy? Is it really necessary? Is it imperative? Can you do treatment without a liver biopsy? So we have another quiz. True or false? If liver enzymes are normal, that means the liver disease is mild and no further evaluation or treatment is needed for someone who has hepatitis C. True or false? The answer is false. Liver enzymes may be very much normal, but that does not mean that the disease is not progressing and that you don't need to either do further evaluation and or treat. So the pathway to a sustained viral response, which is actually what we're aiming for with hepatitis C treatment. The first step, of course, is to identify the person as having hepatitis C, most likely through screening. Appropriately referring to the person to a hepatitis C specialist if available. And is the person interested in treatment? Just like in HIV care, the patient has to be the captain of the ship. They have to be willing to commit to treatment. They have to be knowledgeable about what the potential side effects of the medication are, what the commitment to treatment looks like. A year-long commitment is a long time for most individuals. And who's going to pay for treatment? Is there a viable payer source? So you've discovered that they're a candidate for hepatitis C therapy. Is there liver disease that's going along with this? Or are there other comorbidities, meaning are there HIV comorbidities? Do they have other disease problems? Are they anemic? Do they have other kinds of bone marrow issues? And if all of that is no, and they are believed to be a candidate, then you start the treatment, start the therapy. Hopefully they can complete the treatment, and then you will be left with a sustained viral response, and what most people would consider a hepatitis C treatment cure. So go back to the question of, do we really need a liver biopsy before treatment? There's pros and cons, so really the jury is still out about this. The pros would say the only reliable way to stage hepatitis C disease is through a liver biopsy. And with the results, you can establish the urgency of the treatment. If therapy is difficult, it helps to know how hard to push onward. In other words, if after 3 months of therapy, does it make sense to perhaps stop the therapy, depending on how much liver disease there is. It also allows you to evaluate for other diseases. The cons would say it's an invasive procedure with risks. May not be available, which is the case with many HIV patients who are co-infected. It's not going to change the outcome, and it may not change the decision about whether to treat. And it may not be readily available. So all of us have to really look hard at our own individual situation with our patients, our environment, our medical community, whether there's support, whether there isn't support, and whether or not you can even appropriately get a liver biopsy. These pros and cons came from Dr. Melissa Osborne, who practices out of the Grady system and who's treating co-infected HIV and hepatitis C patients on a regular basis. She would say that no individualized system is the right one, that you need patient input and you have to weigh the risk versus the benefits. So what are some of the established risk factors for progression of fibrosis and cirrhosis? Well, if you happen to be a male, you have a higher risk. The longer duration of infection, how long has the patient in the body been dealing with hepatitis C infection? And was the individual over 40 years at the time of their infection? Not the time of diagnosis, but the time of infection. What about alcohol? In excess of greater than 50 grams a day for men and greater than 30 grams a day for women would be considered an increased risk. If the liver enzymes say persistently elevated, that would be considered a risk as well. If they have co-infection with hepatitis HIV and hepatitis B virus, in addition to hepatitis C? And have they had an organ transplant? Again, just a reminder that we need to constantly remind our patients about their alcohol use and how detrimental alcohol can be to a co-infected individual, not only if you're considering treatment, but also on the body in HIV treatment. This is a nice graph, a little bit of old data, but hasn't changed. The green marks are the hepatitis C virus negative patients, and the yellow, of course, are hepatitis C virus positive patients. And these would be the number of drinks on the bottom of the graph. So greater than 14 drinks, you can see that the odds ratio, or the percentage of odds of developing cirrhosis, is astronomical. And even 10 to 12 drinks, very, very high. So again, more data to show us that we really do need to focus on alcohol use with our patients, as well as other drugs. So treating hepatitis C in HIV co-infected patients, there are guidelines and there are guidances that we can use. These are constantly changing, and I encourage you to constantly look at these. If you have a patient who comes into your practice who does have HIV and you find out they also are co-infected with hepatitis C. The treatment now has changed over the years. We have new generation medications. However, you'll see that interferon is still one of the main staples of treatment, and as well as we also use this in combination with ribavirin. However, this year, March 15th, the FDA basically has considered two other medications for the treatment of hepatitis C. They happen to be protease inhibitors, which may sound like a familiar term given that we use protease inhibitors with HIV medication management. So what about when you have other comorbidities with the HIV hepatitis C co-infected person? Certainly mental health is a consideration as well. As I mentioned earlier, interferon has been known to cause depression or worsening depression, and certainly has been known to cause an exacerbation of mental health disorders. So what about predictors of fibrosis progression? Again, greater than 40 years of age. What genotype do they have? We haven't mentioned this before, but hepatitis C has 3 genotypes. 1, 2, and 3. Genotype 1 tends to have the better of the outcomes with treatment than genotype 2 and 3. Unfortunately, most of the individuals infected with hepatitis C in the United States are genotype 1, which is probably why the data in terms of response to therapy has been less than what we would like for it to be. And again, you can see here daily use of alcohol as well as use of marijuana. What about the consequences of insulin resistance in hepatitis C co-infected patients? There is an increased risk of fibrosis progression, all patient groups, regardless of age or gender. There is a little bit of some controversy about the increase of liver cancer with insulin-resistant patients. We do know that there is an increase in hepatitis C viral loads, and we do know that it potentially can reduce the response to interferon-based therapy. And then I've given you that this also is independent of BMI, obesity, some other liver abnormalities. But it can affect both the sustained viral response as well as the effective viral response. So modifying risk of cirrhosis in patients with hepatitis C, alcohol. Moderate to heavy use, clearly not helpful. We don't have a lot of data on what's called the social use of alcohol. And many times patients use that term when asked how much alcohol they drink. I'm just a social drinker. What exactly does that mean? We probably need to be better at getting a more defined history from our patients. How many ounces is that? How many times a day? How many times a week? But really and truly, abstinence is what we recommend. What about marijuana use? I just showed you on a previous slide that we know that that can accelerate fibrosis. We need to ask our patients how much marijuana do they smoke. We're not sure, there's not great data yet to understand whether less frequent use is harmful. But we know that daily use certainly can accelerate the fibrosis. Insulin resistance and steatosis, they can also be independent contributors to fibrosis progression. And weight loss reduces fibrosis progression. So we know that obesity affects it. Menopausal status may be modifiable as well. Hormone replacement therapy may reduce the risk of fibrosis progression. Our last funny slide about alcohol. Again, can't spend too much time talking about the impact alcohol has on hepatitis C. So the burden of hepatitis C disease. There are an increasing number of persons with chronic hepatitis C developing complications of cirrhosis and hepatitis C, cancer of the liver. Fibrosis progression is not linear. It increases with age and postmenopausal status. There are several modifiable factors that we've recognized, and we as healthcare providers have the opportunity to help the patients modify some of these in order to lessen the disease progression. Estimating risk of fibrosis progression and liver complications is important. And this will be important to decide which patients might defer treatment and which patients need to start treatment. And then also understanding about non-responders. And I couldn't do this presentation without the help and support of, again, Melissa Osborne, who I look to for all the latest information. Thanks so much. And here are some websites for providers, and I've also listed some for your clients and patients. It really does take a village and/or a team in order to treat hepatitis C co-infected patients. And oftentimes, as I mentioned, sometimes just being there to support them is all that's needed. Some other helpful resources are online, but there are also some 1-800 numbers that can be helpful to you. Don't hesitate to use these resources. These agencies and organizations have the most up-to-date information. This is where much of the data comes from. It also is a clearinghouse for the data, so they have the best information available.
This was edited by Elizabeth Fullerton, MPH. With special thanks given to everyone at Emory Center for Interactive Teaching for their support in helping us publish this webinar. Thank you for watching this webinar. Watch this website for more information, www.ctech.emory.edu. Thank you.
The preceding program is copyrighted by Emory University.